Welcome, everyone. Keep enjoying coffee and breakfast. And I know better than to ask folks in this town to turn off Blackberries, so we'll just ask you to silence them. My name is Michelle McMurray, and I'm the director of the health program here at the Aspen Institute. We're really honored today not just to be joined by our august group of speakers for the day, but also by our president and CEO, Walter Isaacson, who wants to give you a special welcome as well. I just want to thank you all for joining us on this historic morning for healthcare. Legislative healthcare reform has moved further than many thought possible, and farther than any other recent efforts to transform the way Americans receive care and get insurance. We've rounded the bend, but the last mile is definitely the longest, and no one can say for certain at this point what the eventual reform bills will look like even when they hit the floor of the House or the Senate, let alone what form a final bill might look like when it reaches the president's desk if it survives those two very important hurdles. After a year of debate, we have still not answered some very fundamental questions. Will there be a public option? If there's an individual mandate, will there be stiff penalties for not complying? Will there be an employer mandate? How will we pay for all of these reforms that we have in mind, and who will pay for whom? But long after these questions are answered, some of the most vital questions in the debate will still remain an unknown. And these are the questions that the Aspen Institute, through our work with the Aspen Health Stewardship Project over the last 2 years, has really sought to keep in the front of the public mind. For example, will these reforms make our nation healthier? Will they plug the holes in the healthcare safety net? How will we afford reform when it actually becomes a reality? These questions may not be answered for generations, but the Stewardship Project really believes that we need to think about the fundamental principles, and we've put those up for you today. This is a longer, ongoing project, and you have one of their reports in your materials, and we invite you to take a closer look. But it's really about saying, what are the vital questions we're trying to get at? And we want to invite you to keep that in the front of your mind as we have our conversations here today. So today we're here to give you a taste of the Aspen Health Forum. This is really our biennial event that takes place out in Aspen. And every time we have it, it's just a fantastic opportunity for health and scientific leaders to have conversations with real people. We bring them face to face with consumers, practitioners, patients, and engage them in conversation over a 4-day period. And what we've pulled together for you here today are some of the most riveting conversations from our last Aspen Health Forum, which took place last July. Now, 3 months in this amazing year is a lifetime in healthcare reform and in scientific progress. Since we met in July, America's view of H1N1 and the emerging pandemic has changed. Our view of health reform has changed. When we met, the town halls had not yet taken place and have now become so famous. So we've not asked our speakers to just recap what they said when they were out in Aspen. We've really asked them to take a new view, a new look on what's taken place since then. And I think it's an optimal time for us to be having them revisit those questions. For those of you who are new to the Institute, welcome. We're based right here in D.C., although we have a beautiful campus out in Aspen where we host many of our meetings, and we invite you to join us both here and there. For those of you who know the Institute well, welcome back. We're welcome to have you. And we're so glad that you're here for our conversation today. I'm going to ask Walter Isaacson, a really visionary leader who really transformed the Institute over the last 6 years into one that not just has really in-depth policy conversations, but also brings those conversations into the public forum to come and say hello. And then after his remarks, we'll show you just a brief highlight reel of some of the conversations over the summer to set the stage for the talks today. Thanks so much.
Thank you, Michelle. Michelle, it's great to be back here. Good to see my friend Tony Fauci after so many times and over the years that he has helped this country figure out infectious diseases. When we were out in Aspen, and I'm glad you're up here on the 5th floor, you can get a sense of what it's like in Aspen, sort of high up and beautiful views. But next time y'all got to come to Aspen, because it was one of the most interesting conversations we had was how the H1N1 virus and others are being attacked. And hey, Jeff Kluger, we do this with Time Magazine. For those of you who know, I used to work at Time Magazine, used to work with Jeff Kluger, and he's just come in, the editor there for all health and medical and science. And so it's great to have a partnership where we disseminate some of the ideas and information. I want to thank AstraZeneca. I know that they've helped put this together along with Pharma, my old friend Billy Tozan I grew up in southern Louisiana. He used to represent me. And I know Medco is doing the dinner tonight, so all of you all, thank you for doing that. The important thing in the healthcare debate is to try to find common ground and to share ideas. It's really difficult in this town at times. I watched some of the hearings yesterday, but it is, when you get out of this town, you realize that there are a lot of people who say, let us figure out how to deal with health care. This can't be something that needs to be so partisan. So that's what we're trying to do at the Aspen Institute. I really want to thank Michelle and Fran Marie Kennedy and everybody else who's been involved. And turn it over to the videotape so you can see some of the highlights from the panel. Thank you.
Isn't this America, the land of the free and the home of the brave? And yet you're asking me to resign myself to an early grave? We've become slaves to cost-cutting measures and monetary gain. And twain the two, there's no room for individuality.
We have to tackle these big changes and make them happen. This is our window of opportunity. And if we don't take advantage of it, I see it as kind of idealism versus cynicism and special interest versus national interest. And it's time for us all to step up and make this happen.
Well, I think the one thing that we know is Americans like choice. And I think as we look at changing the system, that the system we will end up with in terms of evolution will be a uniquely American system.
Our health care results would be equivalent in a nanosecond to Europe and Japan if we didn't live so unhealthy. And that's our biggest problem. If we could get a system that encouraged us, incentivized us to live healthy, we'd be in the ballpark immediately. But that's going to take more than 10 years.
Making science and truth accessible to the public is important, and providing guidance on how to use everything that's an active ingredient toward health is very important.
It's time we pull back the curtain from the food production system and demand that food manufacturers stop false marketing claims and explain what and how much of it is in their products.
Prevention for me is very simply defined as making it easy for people to do the right thing.
Common sense tells you that a lack of exercise among kids, because of a lot of reasons, it may be television, it may be safety issues, maybe parents' working culture, whatever it is. But it's somehow we've got to realize that it's not just about food, it's about movement. And these things have to go together, and that has to be part of our national policy.
Tonight I'm going to demonstrate a ginger panna cotta with a little bit of pistachio, thyme, and I've made it with buttermilk instead of with just a little bit of cream, which actually helps cut down the fat.
You cannot be a wealthy nation if you're not a healthy nation. So we've got a patriotic duty to start to address this thing, and it's going to have to happen at the level of the individual.
Mixture is going to get mixed with the cream.
My name is Patch. I've spent my lifetime in bed to play. I haven't spent 1 minute not playing.
If our adults are stressed and unhappy, you're going to have an unhappy generation and a sick generation.
I mean, if you can look back at the last 72 hours and account for almost every minute, you've been overthinking this.
Good morning. I'm Fran Marie Kennedy, and I have the opportunity of introducing this panel and our moderator, Lynda Carnes. We're starting this morning with strain on the system, and Lynda has been a dear friend of the Aspen Institute for quite some time. She is currently the Senior Marketing and Communications Officer at CDC, and prior to joining CDC, she served as a senior policy advisor to the White House Office on National AIDS Policy. In addition to that, she was a technical operating manager for reproductive health management and family planning at USAID. She is currently serving as the Aspen Institute Stewardship Advisor, as well as that of the Global Health Initiative. Welcome, Lynda. She's going to moderate and introduce the panel and introduce the topic.
Good morning. Welcome to our program. The 2009 flu season officially began October 4th, and we're a bit more nervous this season than most. Why? Well, mostly because this season is more complicated and more unpredictable. Why more complicated? Because of the emergence of a new H1N1 influenza virus that has caused the first influenza pandemic worldwide in more than 40 years. Why so much uncertainty? First, timing. When will it hit us? Second, severity. Will it be hard? Will it kill many more of us than in normal past flu seasons? And third, protection. Do we have vaccines that will work and enough to go around? Fourth, length of the season. How long will it last? Now, each week, CDC analyzes information about influenza disease activity in the United States. 3 weeks ago, a review of the key indicators found that H1N1 activity remained elevated in the United States. For example, 99% of all influenza A viruses reported to CDC were H1N1 viruses. 99%. 11 influenza-associated pediatric deaths were reported, and all were associated with the H1N1 virus. 27 states reported geographically widespread influenza, and 3 weeks ago, CDC reported over 9,000 H1N1 hospitalizations and almost 600 deaths. Now, our most recent data as of October 2nd reports over 16,000 flu and pneumonia hospitalizations. That's almost double the hospitalizations from the 2 weeks prior. And almost 1,400 deaths. That's more than double. And flu is widespread in not 27 states, but now 37 states. In sum, all of our trend indicators are up. Our goal today is to give you a sense of what the upcoming fall influenza season has in store for us, especially with the complication of two viruses to address at once, our normal seasonal flu and the H1N1 virus. I'm joined by two of the world's foremost health experts to share their special insights. First, Dr. Anthony Fauci, Director of the National Institute of Allergy and Infectious Diseases at the National Institutes of Health, and Sir Richard Feachem, Professor of Global Health at the University of California, San Francisco. Dr. Fauci will begin with an overview of the remarkable and unique aspects of this fall's influenza season. He will share with us the special challenges for public health, his commentary on the supply and effectiveness of the 2009 vaccine, and Sir Richard Feachem will focus on the global perspective, what we can anticipate for the rest of the world over the coming months, the special impact on low and middle income countries, and looking forward, H1N1 as a pandemic and what this really means for all of us. Dr. Fauci.
Thank you very much. It's a real pleasure to be back with you again after this discussion, which is interesting to put the comparisons of how this has really evolved over the last several months since we discussed it in a similar panel in Aspen this past summer. So let me just very briefly describe for you what has evolved over this period of time and to bring you up to date on what I had told so many of you this past summer vis-a-vis where we were with regard to one of the major countermeasures for a influenza epidemic, and in this case pandemic, namely vaccines. Well, as you heard from Lynda, it has evolved and continues to evolve. This is a very unusual situation from the standpoint of the people who monitor influenzas for a living. It's unusual because it was first recognized at the very end of the classical seasonal flu, which made it very, very unusual. In April, both here in the United States and in Mexico, we had a cluster of cases of a brand new virus that, although it's designated H1N1, and that confuses people because H1N1 first came upon us in 1918 with the pandemic influenza that was so historic in its devastation, and has been around except for a 20-year gap ever since. And in fact, part of our seasonal flu vaccine contains a component that's an H1N1. But this was very different. It was a virus that had molecularly assumed the characteristics of 3 separate genetic backgrounds: bird, human, and swine. Had been literally living in swine for about 10 years until it jumped species, and then we had what we had in April. From an epidemiological standpoint, this is going to go down in the history books as a classical case of a highly transmissible virus. Many of you are aware that we had been monitoring the H5N1 bird flu in Southeast Asia now since 1997 and intensively since 2003. That virus has now infected about 450 people and killed about 260 over a period of many years. So its characteristics are that it is poorly transmissible but highly lethal, 50% lethality, but very, very poorly transmissible. Along comes the H1N1 2009 virus, and within a period of a few months, and we were right in the middle of it in Aspen in the past summer, we saw an explosion of transmissibility across the United States and throughout the world at a time when we should have been finishing our flu season. It's a very interesting curve that you can get out of the CDC website, where they show different flus that peak in the winter, come back down, and virtually disappear in April and May. We saw a little blip because the children were still in school in the United States. Now, Richard will talk about the global situation, but the blip that we saw was children who were still in school. And then it looked like it was going to go down because school ended at the end of May and the beginning of June. But a very telltale pattern on that particular curve was that it never went back down to baseline. So we never were free of pandemic flu this summer. And it was a bit over baseline, which was really reflective of children in summer camps, people in recruiting centers for the military. And it went along like this until the end of August and the beginning of September, when it blipped right up. And what we're seeing now is like this. And the big unknown that we're tracking right now is this going to keep going way, way, way up and stay up? And when is it going to peak? Will it come down? Will there be multiple waves? And we don't know that. But as you just heard, the one thing that it has done here in the United States and throughout the world, it has pushed seasonal flu off the table. So more than 90% of the isolates are H1N1 2009. And if you look, and I'll leave that for Sir Richard to talk about, if you look at what's happened in the southern hemisphere globally, in Argentina, Chile, South Africa, Australia, and New Zealand, they had a flu season with H1N1 as opposed to seasonal flu in the absence of a vaccine. So there's going to be some very interesting information that we're going to get, because we have half of the world now had a flu season with H1N1 without a vaccine. Because we began making the vaccine in April, and remember, I reported that we were beginning our clinical trials, and I have some good news that's no longer news because we've been announcing it over the last couple of months. We did not know whether the vaccine that we were making would be immunogenic. Namely, would it induce an immune response that would be predictive of being protective? And the reason there was a concern, because when we made a vaccine against H5N1, the bird flu, it was a vaccine, but it was very poorly immunogenic. It induced an immune response in less than 50% of the people, and it required an enormous amount of antigen in 2 doses to do that. So when we did the clinical trials over the past few months, we found some really good news. A, it was highly immunogenic in individuals who are adults and the elderly with 1 dose of the standard amount of seasonal flu dosage, 15 micrograms. Number 2, it was immunogenic in children. and we only required 1 dose in older children from 10 to 17, and likely 2 doses in children from 9 years old and younger to about 6 months. You know, you don't vaccinate children less than 6 months of age. So where we are right now in this extraordinarily dynamic process is that we have seasonal flu vaccine, which has been around for a while. 70 million plus doses have been delivered for distribution. And we are encouraging the people who should be getting seasonal flu vaccine to get it right now or last week or 2 weeks ago. The most vulnerable of the people who need seasonal flu vaccine are the elderly, because just to refresh your memory, I know many of you know this, each year seasonal flu kills 36,000 people in the United States and accounts for 200,000 excess hospitalizations. Of those 36,000, 92% are individuals older than 65, and the majority of them are older than 80. So the risk people are the elderly and people with underlying disease. The striking difference with this flu is that, for reasons we can get into, I'll give you a little hint, probably because elderly individuals have been exposed over decades to viruses that have some degree of similarity to give them some background protection. But if you look at the curves of hospitalizations and deaths, it appears that the 65 years of age and older are relatively protected. All of the serious disease, even though it's fundamentally a mild to moderate pandemic, virtually all of the serious diseases in the younger individuals, pregnant individuals, people with underlying conditions. And that's a very difficult message to get across. We're dealing with fundamentally a relatively mild pandemic, but in those relatively small percentage that get seriously ill, it's highly weighted towards younger individuals. And that's the reason why, and I'll close with this, why the 5 recommended groups in this country and globally who should be receiving the H1N1, which is literally rolling in now. A week and a half ago, we got the first 600,000 doses. At the end of that week, 6 to 7 million, and now they're rolling in at 10 million per week of the H1N1. As I mentioned, the seasonal flu vaccine is already here. The 5 high priority groups, or people who should be targeted, are pregnant women, because pregnant women have 6 times the probability of getting serious disease from flu than non-pregnant people. The caretakers of children less than 6 months old, because you can't vaccinate a child less than 6 months, so the second best thing is to vaccinate the people around them to protect them. Healthcare workers, young individuals from 6 months to 18 years old, and individuals from 18 to 64 who have underlying conditions. Notably absent from those groups are elderly individuals, because they are the individuals who appear to be protected. That doesn't mean that they shouldn't be vaccinated. Once we get the 5 priority groups vaccinated, we're certainly going to want the elderly individuals to come in and get vaccinated. So I'll stop there, and I'm sure we're going to have a lot of fun answering some questions later. Thank you.
Thank you, Tony. Sir Richard?
Well, good morning. Good morning, ladies and gentlemen. Great pleasure to be here. Thank you, Lynda. Thank you, Tony, and thank you to the Aspen Institute for the invitation. My role is to set the current H1N1 events in the United States in a global perspective and to look forward to what we might expect worldwide over the coming months. And of course that's appropriate because by definition a pandemic is a global epidemic, and we have to see what's happening in a global context. I'll make 9 very brief points about the global context. The first one is that the 21st century will be a century of pandemics. Some of them will be modest, some of them will be devastating. This is a foretaster of a century of pandemics, mainly viral in origin. And if not viral, they'll be caused by multiply antibiotic-resistant bacteria. So there's much more of this to come. Some of these pandemics will be chronic, by which I mean they will rise and fall over decades. And some of these pandemics will be acute, by which I mean they will rise and fall over months. We are in the middle of the biggest pandemic that the world has ever known, that Homo sapiens has ever experienced. And it is a chronic pandemic. It has risen and it continues to rise over decades, and it will fall over decades in the future. And that, of course, is HIV/AIDS. It is devastating. It continues to run very strongly around the world. Rates in many countries rise. Rates in some countries have plateaued, but it's far from over. And our success so far is in treatment, not in prevention. We have been largely unsuccessful on a global scale in preventing HIV infection. The other pandemic that is currently upon us, although we don't notice it very much yet, but I want to mention it, is the pandemic of multiply antibiotic-resistant tuberculosis. This is again a chronic pandemic. It is rising quietly, slowly, inexorably, but it's got a long way to run, and it will cause us a lot of difficulties before we get on top of it. And it's a pandemic which, for reasons we could discuss, we are relatively scientifically naked in the face of this particular challenge. Coming now to acute pandemics, and as Tony has mentioned, we were watching H5N1 very closely before H1N1 came along and knocked it off the headlines. And H5N1 has one of the two properties that we fear in any pandemic virus. The two properties that we fear are easy human-to-human transmission and a relatively high case fatality rate, the ability to kill a high proportion of people who are infected, and particularly a high proportion of otherwise healthy people. Those are the two properties we fear. H5N1, as bird flu, H5N1, as Tony mentioned, has one of those properties but not the other one. It is not easily transmitted from human to human. That's very good news. But it is highly fatal. It has a high case fatality rate. About 59–60% of known infections, and I emphasize known infections, with H5N1 around the world have died. That's a very high case fatality rate. But it's not, at the moment, easily transmitted from human to human. Now along comes H1N1, which is the opposite. It has easy human-to-human transmission, but it is not, fortunately, at the moment, a very fatal virus. It is typically a rather mild disease that results from infection with H1N1. But its ease of human-to-human transmission is quite remarkable. If you track the spread around the world week by week from the index cases in Mexico in April, within 10 weeks it was in 150 countries. That is remarkable. This virus really hops around the world very quickly, and that's all human-to-human transmission, and that happens readily. That second property is not yet a feature of H1N1, and we hope that it won't be, but we can't be sure that it won't be. On a global scale, dealing with pandemics is the global public good par excellence. It requires a unique degree of collaborative multi-country action. There are no winners and losers in pandemics. There's no such thing as we'll protect ourselves and what happens in our neighbors is up to them. Pandemics are essentially we all swim or we all sink. And if we look at pandemics today, HIV/AIDS, the emergence of resistance, TB, H5N1 continuing to tick along, and now H1N1 running strong, and we ask questions about our global capacity to identify very early the new strain, perhaps in Southeast China, perhaps in Vietnam, perhaps in Indonesia, in the case of H1N1, perhaps in Mexico, identifying it very early. We're not very good at doing that. Containing it so it stays there and doesn't start spreading rapidly around the world. We're not at all good at doing that. We failed in HIV, we failed in resistant tuberculosis, we failed in H5N1, and we failed spectacularly in H1N1. So we don't contain. And then having failed to identify early enough and having failed to contain, can we cope? Well, history will show whether we can cope. But my prediction would be, if we get a virus that has both of the properties, easy human-to-human transmission and high fatality rate, then we will spectacularly not cope. And the scale of death and economic consequence will be very, very large. We remember what happened in 1918, 1919. The scale of death was huge, much larger than all casualties during the First World War, much larger. About 16 million people died in the First World War. Something between 50 and 100 million people died in the flu pandemic that came the year after the First World War ended. So the scale of death will be enormous, and the scale of the economic consequences will be enormous, and it really is a challenge to form new global arrangements for identification, containment, and coping when these new strains, which are potentially pandemic, emerge. My last point is that if we look at the winter that is ahead of us, the next 6 months or so, I think we will see two worlds emerging quite noticeably. There will be the 50 countries in the world that are wealthy and have reasonably good health systems, have an ability to vaccinate a high proportion of their population, and have access to enough vaccine. So about 50 countries in the world, perhaps 1.5 to 2 billion people living in those countries. And we can expect that maybe half of the population of those countries will get vaccinated. And as a consequence, and also hoping that H1N1 remains a mild disease, we'll have a bad flu season, but it won't be spectacularly bad, and the consequences will not be too serious. But the rest of the world, where the other 4.5 to 5 billion people live, the 150 countries that are not in my first category, none of those things will be true. The majority of the population will not be vaccinated. A very small proportion will be vaccinated for two reasons. One is they won't have enough vaccine. And secondly, the healthcare system and the arrangements for getting vaccine to people will not be adequately strong. So most people will not get vaccinated. And therefore, for the more seriously ill, the consequences will be fairly dire. And when people do become seriously ill, when that proportion of those infected that are going to become seriously ill, they won't have access to the hospital facilities and the intensive care units that people in the wealthy countries of the world will have. So I think we can expect a very bad flu season in those 150 countries with weaker economies and with weaker healthcare systems and with much lower vaccination rates, despite the efforts that are being made currently to donate through the World Health Organization and through the work of the major vaccine-producing companies. There are major efforts to donate vaccines to the poorer countries, but it won't be on a scale, and the delivery of those vaccines will not, I expect, be sufficient to really attenuate the pandemic that will come through the winter. So I think we can expect a much more serious situation in the poorer part of the world, and that will be the case even if H1N1 stays as it is, which we all hope it does. If, on the other hand, H1N1 evolves to have more serious pathologies and a higher fatality rate, then I think things will look really very dire, particularly in the poorer parts of the world where the great majority of the world's population live. So let me pause on that and pass back to Lynda.
Sir Richard, you make reference to the issue of coping. How will, and for Tony as well, how will the H1N1 virus strain our public health system, not only domestically but globally? You've referenced it a little bit. But most importantly, what indicators will we have? Social indicators, indicators on the ground that our system is over its head.
Well, certainly it's going to be a challenge, particularly if we have the peak that I was referring to in my opening remarks continues to go up. I don't think, as Sir Richard alluded to, if the virus stays in its present form of highly transmissible, but relatively speaking not quite virulent, only in a very small group of people, I don't see at all an overwhelming of the healthcare system. If you look at what happened in comparable countries like Australia and in cities in Argentina, when they went through their flu season in the absence of a vaccine, they were challenged in their healthcare delivery system, in their emergency rooms and in their intensive care units, but it wasn't an overwhelming situation. So I see that what will happen is if we can get, and this is a difficult thing to do, the CDC has been trying to do this, is to get people to realize that if you get symptoms of a flu, you don't necessarily have to always go to the emergency room. You can call up a physician and describe your symptoms, and or even not necessarily even a physician, even a nurse or a nurse practitioner in a physician's office, and say, this is what I have, what do you recommend? And they would likely say, if you're healthy, if you're not pregnant, if you don't have an underlying condition, it is highly likely that you don't need to get an antiviral like Tamiflu and that you could be taken care of at home. You get into difficulty when everyone panics and comes to an emergency room or to a clinic. And I say that, and I know that human nature will be that people will still do that. But if we can continue to get the message across that unless you start to develop symptoms that are significant, that you should not do that. If we don't, I think we'll be okay from a healthcare coping standpoint. And Sir Richard, yeah.
Well, I mean, very much agree with that. Again, for the wealthy countries, for the United States, Western Europe, Japan, Australia, etc. I think across the low and middle income countries, we will see a different story. Very large numbers of cases have an ability to overwhelm an already very weak healthcare system, and those facilities for the extremely ill, for example, in intensive care units, will be largely unavailable to the majority of people in the low-income countries. So I think it will look different.
You know, I just want to underscore something that Sir Richard has been saying for years and years. Of course, I've heard him say that for years and years. When you're dealing with poor countries and you have conditions that any disease strikes them harder than, though it doesn't necessarily have to be influenza. And I think we're actually seeing a bit of that now, because there are reports, for example, from big cities like Chicago, that if you look at the number of individuals, the proportion of individuals on an economic and ethnic racial standpoint that require hospitalizations and get sicker, if you're in the middle of the city, like Chicago, and you are an African American or Hispanic, and you live in an inner city area, the chances of your getting a more serious form of the disease is greater. And it isn't biological because you are an African American or a Hispanic. Is because there's a greater chance, A, that you're poor, B, that you have diabetes, C, that you're obese, D, that you have cardiovascular and lung disease, including asthma. So if you look at the prevalence of the underlying conditions in certain populations, so if you go into a country that's poor in which there are these diseases more prevalent, I think it's underscoring what Sir Richard is saying about that they will likely be hit even harder because of a number of factors, including that.
Let's open up for questions. Please.
Just, I don't understand how these various viruses morph. And so with H5N1, what are the odds of it morphing so that's more easily transmittable human to human? So how long can we count on the fact that it's hard for it to move to the human species from the avian species? then with H1N1 again, how do we watch for morphing of that particular virus as something that's a little bit more dangerous than the H1N1 we see today?
Right. Well, you've asked a question when you said, what are the odds of this? There's no answer to that because you can't tell what it is. But I can give you some information briefly that maybe you'll put it into a more understandable context. The H5N1, the famous cover your butt answer of all scientists is that influenza is completely unpredictable, therefore you can't say what will happen. But having said that, now I'm covered. The fact is that H5N1 has been circulating around now for over 10 years. It is unlikely that that is going to mutate into a highly transmissible form. Impossible? No. Likely? No. Unlikely? Yes. It's unlikely that that's going to happen. When you have a virus like H1N1, viruses tend to mutate when there are external pressures on it to change what it is. It could be a certain fraction of the population becomes immune, and instead of easily infecting everyone, it starts to get pushed by the immune response. Intervention by antivirals, environmental changes, and others. So right now, the H1N1, as you've heard both from myself and from Sir Richard, is having a fantastic time easily spreading around the world. There's no evolutionary pressure for it to mutate differently. So it is likely that at least through this round of infecting people throughout the world, that's the reason why we've seen that the virus that we isolated in April of 2009 is identical to the virus that's circulating globally right now. And that's probably because there's very little reason for that to be pressured to mutate. What happens when 2/3 of the population becomes immune to it because it's been infected? Then you're going to start to see the drifts in virus that you see every year from one season to another. What we hope doesn't happen is that it shifts and changes a lot to the point where it becomes more virulent.
And just to add to that, that was a great explanation of what we know. And to add to that, in addition to those processes that Tony just described, there is the constant exchange of viruses between domestic fowl, mainly chicken, and domestic pigs and humans, particularly in Indonesia, Vietnam, and parts of China. And that is added to by wildfowl who drop in to visit from time to time. So you've got this kind of virus churning going on where farm birds, pigs, and humans are swapping viruses with each other constantly. And it's that process that is throwing up new genetic forms. And they will surprise us. I mean, it's things will emerge in the future, some of which may have both those properties.
Good morning. As I've listened to discussions about the vaccine, I hear a lot of public concern about adverse reaction to the vaccine itself based on the swine flu vaccine years ago. So the first question is, what are the percentages of adverse reaction? And the second is, are there plans for a communication strategy to counteract some of the public concern?
Let me give it a shot since we've been, and Sir Richard, I'm sure will chime in. Since we've been doing the testing on this vaccine at NIH, you've got to separate the issue of safety of what you might consider a brand new vaccine. And this is, to me, the most difficult message. I must have said it 100,000 times over the last couple of months. This vaccine is made by the same companies in the same way, with the same materials, with the same processing, as the seasonal flu vaccine that we make every year and changing the strain a bit. So when you talk about safety track record, and that's when you hear people, oh, I don't want to get my child vaccinated because this is a vaccine that's untested. Well, we have tested it in several thousand people in clinical trials, and there's no safety red flags at all. Pain, swelling, anytime you inject somebody in the arm, that's what you get. But what we do have is a backlog of a track record of safety of seasonal flu vaccines that we've been given for decades to literally hundreds of millions of people. So the safety profile of this type of a vaccine is superb. Is it 100%? No. You asked a question about the swine flu in 1976 when we had the Guillain-Barré associated with that. We had not seen Guillain-Barré syndrome before nor after that 1976 episode. But the point that I continually make is that whenever you make a decision about a medical intervention, including a vaccine, you balance the risk with the benefit. In 1976, the inadvertent mistake that was made is that the vaccine was manufactured, and the decision to manufacture it was coupled with the decision to administer it. And there was about a couple of hundred recruits in Fort Dix, New Jersey, who got this brand new virus, the swine flu. One died. The virus never got out of Fort Dix. So instead of waiting and seeing whether there was going to be a pandemic, we, the United States, vaccinated 40 million people. And then we found out that there was a small increase in a serious adverse event called Guillain-Barré syndrome. Now, the problem with that is that there was all the risk of the vaccine and no risk of the pandemic, because the pandemic never materialized. If we had had a pandemic in 1976 where thousands of lives would have been saved by the vaccine, no one would have been talking about Guillain-Barré. What we have right now is a pandemic that's a global pandemic. So it's no longer a theoretical risk of a pandemic. We are in the middle of a pandemic. So when you balance the risk-benefit of a vaccine, it's overwhelmingly leaning towards the risk of the vaccine is far less than the risk of the disease itself.
Hi, my question is for Sir Richard. You talked about a pandemic that I don't hear very often, and that is multi-antibiotic resistance tuberculosis. Mm-hmm. Can you talk a little bit more about the consequences of that and also your prognosis for other antibiotic-resistant disease?
Yes. I mentioned so-called MDR, which is multiply drug-resistant tuberculosis, and the more serious and scary XDR, the extremely drug-resistant tuberculosis, because I see it as a creeping pandemic. And what we found over the past decade or so is that as a result of the greatly scaled up programs around the world to treat tuberculosis, we have applied to the tuberculosis bacillus exactly the kind of selective pressure that Tony was talking about earlier. And we have encouraged the spread of strains of tuberculosis, which in the case of MDR are resistant to a group of antibiotics, and in the case of XDR are resistant to pretty much everything we can throw at them. The problem with these strains, in the face of continued selective pressure, and there is the continued selective pressure because we continue to roll out the regular anti-TB programs, is that they're extremely difficult to treat. They're extremely difficult to diagnose early enough to do the right thing, extremely difficult to treat. There's a very high case fatality rate, even in patients who are admitted to good hospitals. So these are very serious infections, and the numbers are going up around the world quite steadily. There are hotspots. The Balkan states are a hotspot. Russian prisons are a hotspot. South Africa is a hotspot. But it's spreading. We find it in California, mainly introduced by visitors from further south, but also increasingly reported in California and other parts of the United States. So it's early, the numbers are small, but it is growing. And one of the challenges we face is that in the case of rapid diagnostics, so we can identify it very early in the treatment, we're not in good shape. In the case of antibiotics that are effective in the face of this multiple resistance, we're not in very good shape. And we don't have a vaccine at the moment. So there's a big science agenda, which NIH are highly engaged in. It's one of those problems where it's not a question of applying the tools we have. Of course, we have to do that. But it really is an urgent need for scaled-up research and the development of new tools.
Good morning. I'm with Women Heart, the National Coalition for Women with Heart Disease. And I'm wondering what information the government is sending out to healthcare providers for women with heart disease that will encourage them to get the vaccine, because it seems like they're among the groups of 5 categories of people who would need it. And we would certainly do that, but I'm wondering what they're hearing as well from their providers.
Well, as you mentioned, the CDC is, in every message that they give on a very good website, indicates and strongly suggests that people with underlying conditions, including anybody with heart disease, including women with heart disease, get vaccinated as a high priority group. It's a messaging challenge that we need to keep pushing, because as in all messages, particularly when you have some reluctance on the part of some to get vaccinated because of misperceptions about the risks of vaccine, that particularly in people with underlying diseases like heart disease, there's an overwhelming reason why you should get vaccinated. So the message is I think, pretty good by the CDC.
And will cardiologists have vaccines?
Well, unlikely that vaccines will be distributed by cardiologists. What will likely happen is that the CDC has contracted with a group called McKesson, which is a distribution program and company that has picked out about 90,000 sites to ship vaccine to. It's going to vary from drugstores to clinics to schools, doctor's office. It is unlikely that they will specifically target a subspecialty of a physician, like a cardiologist or a gastroenterologist.
But it will be widely available in the community.
Yeah.
My question's about the timing of the vaccines. I was wondering if you can, and it's 2-part, what were the consequences of having the entire southern hemisphere go through the flu season without a vaccine, and how have you seen the consequences of the timing of the flu here in the northern hemisphere taking off before the vaccine was readily available?
Well, it's unfortunate that the southern hemisphere went through their entire flu season, of which more than 90% in many of the countries was H1N1. So they were not given the benefit of one of the major modalities of prevention. We are in a race, as it were. I hate to use that word because then people say, you're rushing it, it's not safe. But it's a safe race between getting the vaccine available. And there are some people already in this country that have lost the potential benefit of a vaccine. We've had outbreaks in many schools. I mean, you've read about it in the newspapers. There were over 2,000 students in Washington State University. If you look at our own schools, even right here in the District of Columbia, you're seeing a considerable number of people. So we're starting off the flu season without the benefit of a vaccine. They are now available. They've come in. The flu mist is in. The injectable is here or will be here literally by the end of the week or the beginning of next week. But we still have had a lot of people get infected prior to that, and that's just unfortunate fact of timing, because we didn't start making the vaccine until April. Usually you decide what seasonal flu vaccine you're going to start making around January. So we have a 3-month lag, and that's the reason why we don't have it now fully distributed.
I want to go back to the person who brought up TB. In the 50s, I worked in TB control in San Antonio. At that time, San Antonio had the second highest rate in the country. Now, I thought after the antibiotics came out and things changed, we wouldn't have this problem because we can immunize against mumps, measles, all these other things now. Why can't we do that for TB? Why do we have to have that become a pandemic?
Well, I'll ask Tony to comment as well in relation to what's been happening in the United States over the period that you're describing. But I mean, roughly speaking, the wealthy countries of the world had enormous success, as you indicated, in bringing down TB. So TB was reduced to extremely low levels in Europe and North America over the past few decades largely by effective programs of treatment with an array of drugs which are effective in the treatment of tuberculosis. Meanwhile, in the poorer parts of the world, TB remained a big killer. So the successes we witnessed in Europe and North America were not duplicated in the poorer parts of the world. So about 10, 15 years ago, huge programs of TB treatment began to scale up worldwide. And we started to use these effective drugs on a large scale all around the world. And probably as a result of that, we now see the emergence of this new phenomenon, having brought down, if you like, regular TB to very low levels in the wealthy countries and having reduced it considerably in the poorer countries. A big public health success story, but one of the penalties of that success has been the emergence of new strains of TB which are resistant to the drugs that we have been throwing at it. I mean, Darwin was born 200 years ago and published On the Origin of Species 150 years ago, and he told us what would happen, and he was completely correct. If you apply this big selective pressure, the organism will evolve to be resistant, to cope with that selective pressure. So we now have this new, still small, incipient, but steadily growing form of TB, which is resistant to the drugs that we've been using successfully for the last few decades. On the question of vaccines, we have a very partially effective vaccine. We have a not very good vaccine against TB. It's called BCG. And in some parts of the world it's still widely used, but it's not very effective in preventing pulmonary TB. And we're searching very, very hard for a new and effective vaccine. But Tony,
I agree completely. One of the issues with development of resistance is that we're victims of our own success, because if you treat someone with tuberculosis, it's generally a months-long treatment. After the first couple of weeks, people feel much, much better. And the problem is they feel much, much better, but they haven't eliminated the tuberculous bacillus from their body, and many people stop drug, and then the emergence of the microbe that comes back is resistant to the original drugs. Then when you get sick again and you go to get treated, you find out, oops, the microbe is now resistant to the drugs that we were treating you with before. So there are a couple of things you need, and that has led to a phenomenon called direct observation of therapy, where you actually make sure the person takes the drug for the allotted period of time. The difficulty is that we need drugs, and I spoke about this at a big summit we had in Seattle over the summer. We really do need drugs that transform the therapy of tuberculosis, where you can actually treat people for a much shorter period of time, much more definitively, as opposed to having to rely on a literally several-month course of therapy, which, it's tough to hold on to, particularly when you start to feel better. And it's a natural human nature. Well, I've taken this drug for 3 weeks, 4 weeks. I really feel great. I felt terrible before. Who needs the drug? You stop, and then, boom, you got a real problem.
President Obama has been criticized somewhat in the media for creating so many czars and wizards for different issues and problems and challenges that we have. But if he were given one more shot, I'm going to ask our two panelists if President Obama were to name you, Sir Richard, the wizard of health, and you didn't have to report to the HHS secretary, only to President Obama, and he gave you a very, very open and full portfolio and said, have at it. What would be your top 5 first things you would attack and why? Same question for Tony. I'm giving you a great
Well, the easy questions have been saved to the end. I'm delighted to see. That is a challenging question. I think the United States, particularly now, under the leadership of President Obama and the Obama administration, has just an absolutely unrivaled opportunity historically to show leadership in global health. And we've heard a lot about smart power. I think this is wonderfully smart power. We've heard a lot about health diplomacy. I'm a big believer in health diplomacy. I think the world is hungry and has a great appetite for collaborative U.S. leadership and presence in the great global health challenges of our time. And they are several. Among them, I think, is the science of global health, where Tony's organization and the rest of the United States provides probably more than half of all medical science research on the planet. And so we have a huge opportunity through our scientific strength to generate the new tools and the new understandings. TB is a great example. We need a vaccine, we need better drugs, and we need a diagnostic that gives us a result before the patient dies. And that is the task of basic science and then more applied science. I think the United States can play a huge role there. But beyond that, I think the United States can play a huge role in building the kinds of collaborations with other countries and around the world that will be effective in the face of the global health challenges for this century. And among them, I would put pandemics high on the list. And I would come back to my comment earlier about how poorly prepared we are today in terms of global architecture. We do not have the global architecture in terms of surveillance, collaborative surveillance, to identify the new pathogens early at their point of origin, to work collectively to contain them. If a new virus emerges somewhere in a village in Java, it shouldn't be the responsibility of the Indonesians to contain it. It's a global interest. It's a global good to work together to contain it. And we don't have those architectures sufficiently in place. So I think this is an enormous opportunity, and one where I think the President and his administration in the years to come can do much good for the United States and for the world, and by doing so, exercise that smart power that we hear about a lot in Washington these days, and really maximize the value of health diplomacy.
Thank you.
You know, I could make up something different, but I think Sir Richard said it extraordinarily well. We both have the same interests in global health, and if I were in that position, I would do is what I'm actually doing is telling the administration and the president when they ask, and they do ask not infrequently, about what the way to go. The president already knows that. As many of you know, he has put forth very soon after he began his presidency a global health initiative, and it is the president's global health initiative, which is a $63 billion program, 51 billion of which is HIV, AIDS, malaria, and tuberculosis, and 12 billion of which is maternal and child health care, which is also important. I would add on to that neglected tropical diseases, which have a great deal of morbidity and not necessarily the high mortality. And Sir Richard mentioned emerging infections. And if we do that, I believe we will accomplish so much, not only in the arena of health diplomacy, but also the issue of the globality of everything we do. We have a responsibility as part of the global community to push that agenda, both from a basic science standpoint as well as from a healthcare infrastructure that we can help build and partner with other countries to develop sustainable infrastructure, not to give it to them, but to partner with them. And we've been talking about this for some time, so I agree completely with what Sir Richard said.
Excellent, excellent. I think there was a question over here to the left.
We're accustomed to thinking of the SARS outbreak as a case study in which everything worked out. We identified it, we contained it, we gave it a snappy name. Was that just all of the tumblers falling into place? Is there a reason that this isn't the paradigm for dealing with outbreaks and instead seems to be more of the exception?
Well, I think thank you for raising SARS, because it hasn't come up yet. I mean, I think SARS was pivotal historically in a number of ways. Fortunately, it burnt itself out. It didn't kind of go anywhere, and it probably wasn't a pandemic at all. But if it was a pandemic, it was a micro pandemic. I think we learned a lot from SARS. I mean, SARS was a wake-up call for China in the need to be open and frank about the emergence of new infections in China, and that spilled over into HIV and had a big impact on China's policies towards HIV, and now we believe and hope towards H1N1 and H5N1 and other things that may emerge or incubate in China. So I think there was a big impact on China from SARS. It showed us how quickly these things can travel the globe. I mean, it was in Canada before we could blink, and there were some consequences to that. And the third wake-up call, particularly for the countries of Southeast Asia, was the way in which this micro-phenomenon, I mean, tiny numbers of cases and tiny numbers of deaths, had an economic impact measured in billions. I mean, it had a huge economic impact, although it was such a small event. So I think a lot of wake-up calls from SARS. Fortunately, it sort of didn't go anywhere, and Tony may tell us more about why it didn't go anywhere. But
Ditto to everything that Sir Richard said, but we were lucky. Mm-hmm. I mean, I think that's about as crisp an answer I can give you. We were lucky. It burnt itself out. It has a degree of transmissibility that is not like influenza, which is much, much more transmissible. We instituted low-tech type of public health, 19th, 20th century type things of getting people screened before they go on planes to see if they were sick, giving them yellow cards saying that if you had exposure, please report to a public health person. And it literally burned itself out. It could have been much worse, but it burned itself out. But luckily, so we were lucky that it burned itself out, but I totally agree with Sir Richard said, is that it showed us some very interesting things, not only about transparency, but also about how you can have an enormous economic impact in a disease that just didn't even go anywhere. Could you imagine if it's a disease that really caught fire? We would have been in some serious trouble. Canada itself and Hong Kong and China, they showed pictures of otherwise crowded airplanes that had 5 people sitting in the plane going from Hong Kong to London. Nobody was going on airplanes. It was just extraordinary.
I think all these things we're talking about are also a major wake-up call concerning the relationship between non-human animals and humans, and particularly non-human animals which humans grow very, very intensively in order to eat them. And we really are in a dark room with a big elephant, and we've only caught one part of the tail in understanding where this is leading us in the 21st century. The intensification, the relentless intensification of the growing of non-human animals for human consumption, and the crossover of pathogens from non-human animals to humans. This is what we're seeing, and we're going to see a lot more of it. And at some stage, there's going to have to be some pretty fundamental thinking about how we grow animals for consumption, and how we prevent or try to attenuate this relentless crossover of pathogens from animals to humans.
You may know that, or have heard that we've had a tremendous amount of wonderful, wonderful expansion construction-wise at CDC in terms of our facilities. And our main campus is really quite state-of-the-art now, whereas up until about 10 years ago, we were kind of back in the 1950s if you came to CDC. And one of the things that we built at CDC was this really extraordinary emergency operations center, which looks like something out of, you remember the movie Dr. Strangelove, the war room? Not quite like that, but it gives you kind of a picture of the kind of, scale of this wonderful public health facility that is really designed for us to directly take on emergency situations. And I worked in this wonderful facility back in the spring when we had the H1N1 emergency. And I've been at CDC for 20 years, and so I know about the wonderful work of my colleagues, the scientific people I work with. I'm not a scientist. And I was once again impressed with the work that we did. But one of the things that I'm concerned about, Tony mentioned that we kind of escaped. We, got lucky. And the title of our session today is Strain on the Public Health System. My concern is what's going to happen, or what is it going to take, or what are we going to do when one of these viruses or one of these public health emergencies shows up and we really are overwhelmed? I find that a little scary.
So do I. There are several aspects of it. I mean, some you can correct. I think healthcare reform, you were talking about healthcare reform before, I think has an important part to play to make sure that people actually have the accessibility to physicians in general. And prevention and all kinds of things like that. I think, to be honest with you, and I don't want to seem pessimistic about it, but if you have an overwhelming, even if you have healthcare reform and everybody has access to a physician and we have a lot of preventive issues, if you have an overwhelming public health disaster, there isn't a lot that you can do about it. I mean, it's kind of like saying you want to build up San Francisco that every single building is earthquake-proof, but you get a 9 Richter earthquake. Well, sorry. It's going down. It's going down.
And could I just add to that, to say that in the current healthcare debate right here in Washington and in the United States, which is such an important debate, there is very little mention of the public health function, the population health function. It's all about where most of the dollars go, $7,500 per citizen per year, twice as much as any other country in the world, go to responding to individuals when they become ill. So it is the curative, individualized healthcare system that is getting all of our attention. And that's very important, and it should get a lot of attention. And it's getting all of our attention because that's where all the money goes, and we want to do something about that and make it fairer. So that's all very good. But there isn't much talk about population health. There isn't much talk about public health in the classic sense of prevention on behalf of populations. And CDC are out there, and many other agencies are out there in the United States as the kind of night watchmen who go about their business unsung heroes, preventing things which, would have happened had they not been doing their jobs. But those things don't happen, so they're hard to celebrate. They're literally non-events, but they're non-events caused by the population health and public health agencies and individuals who work for them. And I think when we're over this current round of trying to fix curative medicine and health insurance and runaway Medicare budgets and all our current immediate challenges, we do need to come back to a national debate about investment in prevention and investment in population health, and being sure that we invest adequately in the agencies which deliver those things day after day and night after night. And I think that's a very important dimension. I mentioned $7,500 per citizen per year on curative medicine. How many dollars per citizen per year on prevention? I don't know the answer to that, but I'm sure it's some very small number compared to the curative expenditures. So we do need to get back to that topic.
Sir Richard, you laid on the table zoonotic diseases. Can you talk a little bit about where the integration of human and animal health is going? And then I'd also like you to talk a little bit about the pandemics and any interaction there with intensive agricultural practices that you referenced.
Well, I think, thank you for raising that. I mean, I think the brief story, which I'm sure you're familiar with, is that there is an extremely close connection between the health of animals and perhaps the health of animals and emerging new pathogens in animals, particularly animals which humans have a lot of contact with, and human health. And many of the new and emerging and pandemic diseases that we've faced over the last 10, 20 years and that we face today are zoonotic. They are of non-human animal origin, and for various reasons, in various ways, they've spilled over out of their traditional reservoir in the chicken or the pig or the chimpanzee or whatever, or the duck or whatever it was, or the pig, into humans. We're going to see more and more of this. I mean, I think this is the world we're in, and it's going to get more because this kind of animal husbandry, this kind of agriculture, is getting intenser and intenser and intenser. My wife is from India, and she's a Hindu, and her people discovered 4,000 years ago two great truths. One is don't grow animals to eat them, and the other is don't shake hands, stand a little way away from each other and do this. If we had all done that for the last 4,000 years, the field of infectious diseases in humans would be very different. I hope we will immediately stop shaking hands and revert to this very quickly as H1N1 picks up through this winter, bringing to an end, or we're not going to bring to an end, modifying our intensive animal raising and animal husbandry practices so that it's not a constant reservoir of new infections for humans, is a major challenge, and I think needs serious attention. There's a movement that's sometimes called One Health, which links humans, animals, and the environment, the agricultural environment in which they live and work. And of course, one final point on that, which you'll be very familiar with, is the rampant use of antibiotics for those animals, to make those animals grow faster and fatter and be more appropriate for our supermarkets. And that is another major place where resistance to antibiotics emerges. And we've talked about it, we've done some things about it, but nothing like enough. There's a big agenda ahead of us.
I want you to join me and Sir Richard and Dr. Fauci for joining us, and thank you so much. I hope this has been informative to you. Thank you.
So we just want to invite everyone to enjoy a little bit of coffee. We've got a 15-minute break, and then we'll reconvene for the payoff of medical research and reform with Richard Gephardt, who's the new head of CAMI, the Council on American Medical Innovation, and David Brennan, the CEO and chairman of AstraZeneca, right after this.